Today's subspecialty lecture series title is Infectious Uveitis, and this is for the year 2024. You should be proud of this date because it's the 40th anniversary of the residency program here in Riyadh. After completing my tenure at the King Saud University, I was honored to be given the title of Professor Emeritus of Ophthalmology, which is a lifelong title at the university. I personally take pride in the achievements of this program. The College of Medicine was a home for all of us, and for 40 years we were able to achieve a lot and to become a citadel for the cultivation of leadership in the Kingdom of Saudi Arabia. At the time when we started the program, there was no residency program at the College of Medicine, King Saud University. And definitely there was no residency program in Saudi Arabia. At that time, there were 2 Saudi ophthalmologists when we started. And this took time. There was a general feeling in the population that they want to have Saudization of all jobs. Unfortunately, I told them that Saudization takes generations and it's not overnight. And this became true because in 4 decades, we were able to build ophthalmology in Saudi Arabia. 1984, 40 years ago, there were 2 Saudi ophthalmologists, Dr. Ihsan Badr, the late Ihsan Badr, and Dr. Abdurrahman Al-Ghadayan. Dr. Badr had the FRCS, and Dr. Abdurrahman Al-Ghadayan had the American Board of Ophthalmology, and he had the oral exam, and I was his examiner at the time. Stanford University recognized in an updated release that there are certain scientists that constitute the top 2% of the most cited scientists in the world. And I am proud to be one of this list, together with Dr. Ahmed Abul Asrar, just to let you know that your mentors have also achieved in ophthalmology as well. When we started ophthalmology in Saudi Arabia, there was no idea about the causes of blindness, neither the prevalence, nor the incidence, nor the causes. Medications were sent by the Ministry of Health to the 5 regions of Saudi Arabia, irrespective of the disease pattern, which later on we had to direct the ministry to send the proper medication to the proper regions. At this time, we divided the country into 5 regions: the northern, the eastern, the western, and the southwestern. And for self-evident reasons, we ignored the empty quarter. This was the research department at KKH in 1984, 40 years ago. And we decided to go ahead and find the causes of blindness in Saudi Arabia. We took a stratified, multi-stage, random sample of the Saudi population, and we traveled in caravans throughout the kingdom for a total of 36,000 kilometers. And we examined a sample in their own homes And these are the caravans that we use, the campers that we used during the survey. And we examined them by a team of 5 individuals, a social worker, a nurse, an ophthalmologist, and the coordinator. And the patients were seen in their own homes. And we found out that at that time, 22% of the population had trachoma. And when we repeated this 10 years later, we found only 6% of the Saudi population with trachoma. The sample consisted of a settled population and Bedouin population. Blindness was 1.5%. This is 10 times higher than what's in the United States. The most common cause of blindness was cataract, and the most common cause of blindness in one eye was trauma. Corneal scars constituted a major cause of blindness, and this required an institution like this one to start the penetrating keratoplasty program. We examined patients in both 1984 and 1994, and we found out that the active disease of trachoma was 10% compared to 2% in 1994, to tell you the intervention programs, how it changed the whole population. On 16 September 1985, we established a society. There were no societies. When I put the idea of putting a society in Saudi Arabia, they came and told me, this is politics, and there is no politics in Saudi Arabia. I told them this is a scientific society. After the Saudi Ophthalmological Society, there were 22 societies in different specialties at King Saud universities. On January 1, 1986, we issued the Saudi Bulletin of Ophthalmology, and this was the first issue. And over the years, over 1 year, we converted the Saudi Bulletin into a Saudi Journal of Ophthalmology. At King Khalid Eye Specialist Hospital was a pivot for the advances of ophthalmology in the Kingdom of Saudi Arabia. We started symposium. This was the first symposium, 25 to 27 January 1984. And it was the first symposium to be held in the Kingdom of Saudi Arabia. The goals of the residency program has been the continued pursuit of new knowledge while striving to provide the highest standard of care in academic milieu committed to educational excellence. This was the first group of residents that were admitted to the residency program on October 1, 1984. And you can see some of the faces that you may recognize: Dr. Ali Al-Rajhi, Ali Al-Kaf, Saleh Al-Amru, Uthman Al-Omar, Saad Al-Haddab, Khalid Jubair, Samir Mansouri, and Dr. Hassanin. All of these graduated. Some of them have retired now. To tell you that Saudization takes generations and cannot be achieved in a short period of time. This was the first year of the residency program. The female residents were not shown for their own privacy. On August 2nd, 1990, Saddam Hussein entered Kuwait, and the Desert Storm started. The whole university closed, and all the facilities were converted into emergency mode. And we had to close our program, but we told them that we cannot afford closing a residency program. So we started by having a symposium on Behçet's disease and started the basic science course on October 1, 1984. This was also continued during the Gulf War. Scud missiles flew over the skies of Riyadh, and we had to cover ourselves, and we were told there could be a chemical warfare. So we were given gas masks at the university to protect ourselves from the gases. And in Riyadh, in the period of 1984-1992, I'm giving you the dates because to tell you this program started before the Saudi Commission for Health Specialties and before it was established, and we had our own rules and regulations. We graduated a total of 86 ophthalmologists in 8 years, and this was consistent, high-quality training at the time. When the Saudi Commission for Health Specialties started in 1992, we continued our residency program, and many of our criteria for the residency was adopted by the Saudi Commission for Health Specialties. In this period of 1992 to 2014, 22 years, we graduated 397 ophthalmologists. It's just to tell you that Saudization cannot be done overnight. It needs generations. These are the curricula that we have published for this program. Some of you may have not seen, but they are available. 1984, it was a copy and paste from this American Board of Ophthalmology. And we did take the American Board of Ophthalmology criteria and applied them here. 2007, we had a new curriculum, and 2014, we had revised the curriculum. So we trained competent ophthalmologists. I would like you to take pride in this achievement, and I would like you to carry the torch that we have started several decades ago. We trained educators, scholars, communicators, administrators, not only doctors, but medical experts, collaborators, health advocates. This picture shows King Abdulaziz Hospital 1984 that was demolished and had a new hospital that was built in 1994, but finally we have the new King Abdulaziz University Hospital that was built and opened in 2022. Ophthalmologists that graduated from the program assumed major roles and leading positions throughout the Kingdom of Saudi Arabia. They are in the private sector, in the public sector, in the Ministry of Defense, National Guard, security forces, but also in the academic sector of the universities. Just a graph to show you how Saudization can take place. And you can see here, in 1990, there was 5% of the ophthalmologists were Saudis. In 2015, 61% of the ophthalmologists are Saudis. And in 2022, around 80% of the ophthalmologists in the Kingdom of Saudi Arabia are Saudis. And you can see here the number of non-expatriates and non-Saudis in their ophthalmologists. As the Saudis increased, those decreased in the Kingdom of Saudi Arabia. So our mission in training manpower at King Saud University has been achieved. and we take pride in the achievements of the College of Medicine, King Saud Universities. We achieved a structured residency program, a scientific society, simulated courses, stepwise training, scientific bulletins and journal, curriculum, research, translation and from bench to bedside, symposia, seminars, grand rounds, transfer of leaderships. First Professor Emeritus, which is myself here, was granted at King Saud University. So we are committed to stimulate, encourage, and intensify our efforts to improve our education and clinical skills and to have continuous quality of improvement. And I would like you, as I said, to keep the torch going for generations to come. Education, therefore, is the progressive discovery of our ignorance. Now, there are many books that came out in ophthalmology, but very few were on infections of the eye. And I'm pleased to say that out of the 14 books that we published here at King Saud University, and some of them are with American publishers, were adopted by many residency programs and are given to residents in ophthalmology. The last one that we have is on ocular infections by myself and Dr. Abul Asrar, Dr. Khairallah, and this was the last book on ocular infections. Infections of the Eye was published by Lippincott, and Lippincott published 2 editions of this book. The diagnostic microbiology and cytology, there was no book on such a title, which was also published by Williams and Wilkins, and also Infectious Disease of the Eye with Gil Spolin and Jack Witcher. And there are several other books. So our title today on infectious uveitis is from these books that I'm going to summarize. The private sectors helped the governmental sector in Saudi Arabia. And there was an article with Springer showing that there are organizations that are active in research in the Arab world. But what are they? And among the top 10, the Eye Center is one of them. The first one that is recognized as one of the most active organization in research is the King Khalid Eye Specialist Hospital, followed by King Saud University, the American University of Beirut, Cairo University, King Faisal Hospital, research, the Research Institute in Egypt, King Abdulaziz University Hospital, Ain Shams University Alexandria, and the Eye Center here in Riyadh. So what I would like to say that Saudi Arabia is the leading country in research in ophthalmology. I am pleased to say this, and I hope you will continue this mission in Saudi Arabia. This is a letter that I received from the Dean of Scientific Research at King Saud University saying that we have achieved a list of Elsevier for research in ophthalmology. My mentors, my teachers at the University of California, San Francisco, gave me a lot, and I was able to transfer this leadership to the Kingdom of Saudi Arabia. Michael Hogan, you know him, is at the University of California, San Francisco. He was the chairman of the department at the time. Philip Stuyvesant is the Stuyvesant who described Stuyvesant's SPK. and the SPK, Tygeson's disease, is known after him. Kimura was the chief of the Uveitis Clinic at the University of California in San Francisco, and Dick O'Connor was also at the Uveitis and the director of the Proctor Foundation at the University of California in San Francisco. And Robert Nozick was also at the Uveitis Clinic. I was there and I learned a lot from them, and this is why I'm here to give you what we have learned over the years. Autoimmune insults initiate a chain of events at the molecular and cellular level, leading to relentless destruction of the ocular structures. And therefore, finding the cause of the disease is important in order to arrive at the proper diagnosis and treatment. In the last century, there was a widespread false optimism that sanitation, antibiotics, and vaccinations will conquer infections. Unfortunately, this goal was elusive, and we have witnessed the continuation of ocular morbidity and loss of vision and mortality due to infections. Some infections have been eradicated by vaccinations. Others have been controlled by public health measures. The tenacity of bacteria and the resilience of the viruses have led to the emergence of new viruses and new emerging bacteria. Now, uveitis can be caused by three causes. 1, infectious diseases. 2, non-infectious or autoimmune insults, and masquerades or tumors. Infectious diseases can be classic infections such as tuberculosis, or can be emerging infections such as COVID-19. And emerging infections are now recognized to be a serious threat to mankind. This is one infection of the eye that was difficult to diagnose, but you can see the retinal vasculitis, the optic atrophy, the retinal scar, and this patient was from Jizan and had developed Rift Valley fever, an emerging infection that can cause blindness and sometimes death. The World Health Organization has announced and declared the 21st century as emerging infectious diseases, global alert, global response. And the global village constitutes the world as such, and the global village is causing change in the etiology of many diseases. Why do we have more infections? There is disruption of geographic barriers with air travel. There are 2,000 flights that cross the Atlantic from Europe to the United States every day. And you can see the globalization and the change in temperature because of these flights. Globalization is not only social, political, economic, but also in health and disease. There is growth and development. You know, economists, you put declarations that we have to develop and to consume. Consumption and development and growth causes disruption of the ecosystem and increase the temperature throughout the world. This causes global warming, Deforestation exposes new organisms and new diseases will emerge. Wide use and abuse of antibiotics is leading to resistant organisms and the superbug. Use of biologics and immunosuppressive agents are causing immunosuppression that lead to infections that we did not know before. During your lifetime and my lifetime, you can realize how newly discovered microbial pathogens discovered mankind. Guillain-Barré syndrome, we did not know the cause. Now we know that Campylobacter jejuni can be associated with Guillain-Barré. Toxic shock syndrome can be caused by Staph aureus and strep pyogenes. Chronic post-cataract extraction uveitis may be caused by P. acne. Peptic ulcer. When I was in medical school, they used to tell me peptic ulcer, you can cure it by bilateral vagotomy. Now, two Australian scientists discovered that Helicobacter pylori is the cause of the peptic ulcer, and a peptic ulcer can be cured by a combination of antibiotics. Hepatitis C was not known. We used to call it hepatitis non-A, non-B. Now there is hepatitis C. Bacillary angiomatosis was discovered only after AIDS epidemic. We did not know that the cat scratch disease is caused by Bartonella hensleyi, and this causes skin rash and telangiectasia. In fact, if you see telangiectasia at the optic nerve head, this is Bartonella until proven otherwise. Virus called hantavirus causes pneumonia. We used to call it sin nombre virus. Kaposi sarcoma occurred in patients with AIDS, but we did not know. We thought Kaposi sarcoma is just a malignancy of the skin, and it can cause tumor of the conjunctiva. But Kaposi sarcoma is caused now by herpes virus type 8. AIDS, of course, HIV-1 and HIV-2. T-cell lymphoma, we didn't know the cause of this type of vitritis. Now we know it's a human T lymphocyte virus, or HTLV, which is common in Japan. Lyme disease. In the 70s, doctors used to call it rheumatoid-like arthritis. And now we know that Lyme disease is caused by Borrelia burgdorferi. Bergdorfer is a parasitologist who used to work in Colorado, and he is the one who discovered the tick, and the tick that causes transmission of Borrelia burgdorferi. Whipple's disease is caused by Trophorema whipplei, and SARS and COVID-19 are coronaviruses. You know about them from the press, of course, from the past 2 years. Now, in 2005, Marshall and Warren, both are from Australia. One is internist and one is microbiologist. They were able to discover the cause of peptic ulcer that we said it is Helicobacter pylori. In 2008, Harold Howson was able to isolate and recognize that the papilloma in humans are caused by viruses. It's a papilloma. We didn't know that. Nowadays, everybody is getting vaccinations during their teens with the papilloma virus. And papilloma virus is now well recognized, type 16 and type 18, as cause of cervical carcinoma, and which we didn't know. And Senussi discovered the HIV virus, and Montagnier also discovered it in Paris at the Pasteur Institute. Several other Nobel Prize winners took their prizes because of their discoveries in infectious diseases. In 1994, I wrote this editorial about emerging infections that pose a serious threat in humans. There is trouble ahead, and I predicted that new viruses are at our doorsteps. Previously unknown viruses are coming out and discovering the human race. And this was in my editorials at the Annals of Saudi Medicine. No one knows how many emerging fatal viruses are to be found in the future. And it was emerging infectious diseases should now be considered in differential diagnosis of known disorders. Viruses can adapt, change, mutate, and jump species from animals to man. Constant pressure on the medical community is being applied with these new viruses. Now coming back to infectious uveitis. If you want to group them into two groups, I like to put them under two titles: immunocompetent hosts, infections that occur in the immunocompetent host, and this include bacteria such as spirochetes, mycobacteria, nocardia, meningococcus, brucella, serratia, bacillus. All these bacteria can cause uveitis in immunocompetent hosts. Fungi such as aspergillus and fusarium can also cause uveitis. Viruses such as herpes zoster and herpes simplex can cause mostly anterior virus, but also can cause posterior virus and acute retinal necrosis syndrome. Parasites such as toxoplasma is a well-known cause of infections of the retina. Rift Valley fever, we talked about it, rickettsia, West Nile viruses, and dengue fever can cause the uveitis to occur. Now, the other group of infectious uveitis include immunocompromised hosts, such as Mycobacterium avium intracellulare, fungi such as Candida and Cryptococcus, viruses such as CMV, parasites such as Toxoplasma, and other infections. I'm not going to go over each one and tell you, but I'm going to take them as a group and tell you about infectious uveitis. What are the spirochetes that cause ocular infections? And this is an important group of bacteria. These spirochetes do not cause pus. They cause granuloma. And you have to keep this in mind in order to understand not only the pathogenesis, but the manifestation of the disease. First, Treponema pallidum, which is the cause of syphilis. And this is an important spirochete that can hide from the immune system, and when it dies, it causes granuloma, but there is no pus with it. These are bacteria, no pus bacteria. Treponema pallidum endemicum is the cause of Begel. Begel used to be common and endemic in Al-Ula and in the northern, western part of Saudi Arabia, like in Tabuk. But it is well recognized that approximately 18% of the population in Al-Ula have positive antibodies for spirochetes, Treponema pallidum endemicum. And you cannot differentiate the seropositive serology of treponema in Bejel and syphilis. You cannot differentiate them. And this is why one has to be careful in the diagnosis of these bacteria. Borrelia burgdorferi is the cause of Lyme disease. Leptospira interrogans and Leptospira biflexa. These are Leptospira spirochetes that can cause uveitis. In Saudi Arabia and in the Middle East, these spirochetes are the most common cause of uveitis in horses. If you have a horse with uveitis, it is Leptospira until proven otherwise. Now let's take Bejel. Bejel is a disease caused by Treponema pallidum endemicum. The primary lesion occurs as mucus patches of the membranes. There is a papillary eruption, and there are moist lesions on the mucocutaneous surfaces. Usually, it is transmitted by drinking vessels, especially when you take the milk from camels. It's not pasteurized, and you drink it in vessels and pass it to the second in line, and you end up in transmitting Bejel from one person to another. We saw 17 cases of Bejel here at King Khalid Eye Specialist Hospital. My colleagues from the States and Europe, when they were here, they were diagnosing them as syphilis. But there is no way that these patients have syphilis. And these patients had Bejel. 2 of the 17 that I saw had destruction of the nasal cartilage. This is one of them, and this is the second one. And you can see that the right eye of this man is physical because of chronic uveitis that was not recognized. 1 injection of benzathine penicillin is sufficient to cure the disease if you make the diagnosis. Some bony changes occurred in 5 out of 8 patients that we saw, and usually you get pericystitis associated with bowing of the trabea. In the 17 cases, we found them with positive fluidic serology, positive VDRL, positive FTA-ABS. There is no way the only way you can do it, you differentiate Bejel from syphilis is by specific FTA-ABS and by PCR. The disease can cause posterior uveitis, and as I mentioned, you get granulomas, and sometimes you get Busaka nodules. And if you look carefully at the retina, you find evidence of bone spicules, pseudoretinitis pigmentosa in patients with syphilis and patients with Bejel. In syphilis, the disease is caused by Treponema pallidum. It's a spirochetes. With motility, it moves, and it has a coil shape. It's elongated. It's 0.2 micrometer by 20 micrometers, and it can be quite long. The disease can cause 2 clinical types: the congenital syphilis and the acquired syphilis. The acquired syphilis, you get a primary lesion. The primary lesion is a chancre, and usually it's a painless chancre. Unlike painful chancre, which is caused by Haemophilus ducreyi, this is caused by spirochetes, and it is usually painless. It can occur around the mouth or genitalia. And secondary syphilis is the second stage of syphilis. The primary lesion may last for 2 to 4 weeks, and it heals spontaneously, and then the spirochetes spread throughout the body, and may stay there from 4 weeks up to 2 years in the secondary stage of syphilis. Latent syphilis may occur without clinical signs, and late or tertiary syphilis can occur later on with multiple granulomas, as well as neurosyphilis, which is difficult to treat, and it has to be treated with intravenous penicillin. Secondary stage of syphilis is characterized by anterior granulomatous uveitis. Remember that these are spirochetes. They do not form pus. They form granuloma. There could be roseola of the iris, which is granuloma of the iris, Kepi and Busaka nodules, choroiditis, retinitis, chorioretinitis, and retinal vasculitis, as well as papillitis. As you see, we call it chorioretinitis and not retinochoroiditis. Toxoplasma is a retinochoroiditis. This is chorioretinitis. Tertiary syphilis causes chorioretinal infiltrates, vitritis, papillitis, optic neuritis, and necrotizing retinitis, especially in patients with AIDS. This is a 23-year-old male who came to me on topical steroids because of anterior uveitis. You can see these small, medium-sized KPs, which are granulomatous in nature. And these lesions are typical of syphilis. The incidence of syphilis is increasing both in Europe and the United States. And it's very important to do tests for syphilis when you see a patient with uveitis. This patient was diagnosed as having anterior granulomatous uveitis, but was not given the proper antibiotics. And you can see here in the second slide showing also larger granulomatous uveitis. Keep in mind that if you have granulomatous uveitis and you give the patient topical steroids, they may convert from granulomatous to non-granulomatous. And if they are non-granulomatous, you may mistaken it as HLA-B27 disease and so forth. But you have to keep in mind that if you use topical steroids, you can convert the KPs into a non-granulomatous category. These are medium-sized to large keratic precipitates in this same patient. And this is the skin of the patient. And this is, just to tell you, this is secondary syphilis. And secondary syphilis causes maculopapular rash, which is elevated and scaly. And you should not shake hands with these patients because each scale contains millions of spirochetes. And they fall on your leg, and you might get the disease by just shaking hands. So it's very important to keep in mind that these patients also develop rash at the soles and palmar rash, one of the few organisms that can cause palmar rash is syphilis. So if you have a uveitis and the palmar rash, this is syphilis until proven otherwise. It's very difficult to find out. There are some other like meningococcus, measles may cause, but they don't cause posterior uveitis. But if you have posterior uveitis and you have, or anterior granulomatous uveitis, and you have a skin rash, this is syphilis until proven otherwise. This is the posterior segment changes that you can see. You can see the evidence of vasculitis. It's because of the vitritis, it's very hard to see the optic nerve, and we call the optic nerve headlight in the fog appearance because of the vitritis. You get vasculitis with these patients, and you get a retinitis and retinochoroiditis, chorioretinitis. This is another patient showing the horizontal vasculitis and the retinitis, which is juxtapapillary. And this patient had positive serology for syphilis. And this is another patient with placoid retinitis. Placoid retinitis, you don't see much of the vitritis, but you can see the changes in the posterior segment of the eye. And this is important to recognize because placoid retinitis in patients with syphilis can be difficult to treat if you are not treated early. There is no culture for Treponema pallidum. You can do direct detection with the dark field microscopy, and you have non-specific antibody tests such as RPR and VDRL. VDRL can be very helpful for you if you do the quantitative, especially in secondary stages of syphilis. When you treat them, it goes down, and you know that the patient is responding to you because the antibodies, the VDRL titer, comes down on treatment. And specific tests for treponema include the FTA and the mycohemagglutinin tests. So the lab diagnosis includes FTA, ABS, VDRL, TPHA, HIV. Serology is done in these patients because sometimes they have a mixed infection of AIDS and syphilis, and lumbar puncture to rule out neurologic syphilis, neurosyphilis. The treatment of syphilis includes one injection in the primary. You can give them 2.4 million units IM once. Alternate drugs, you can give doxycycline or azithromycin. And the cure is if you have in primary and secondary, you can cure them very quickly. But neurosyphilis may take more time, and they might need intravenous penicillin and admission to the hospital. Now, another spirochete that causes uveitis is Borrelia burgdorferi. Borrelia because it is in the family of Borrelia spirochete, and Burgdorferi because Dr. Bergdorfer described this tick that transmits the disease in Colorado. There are three types of ticks that are important. The Ixodes damini is the most common. You have Ixodes pacificus, which lives in the western part of the United States in California. There is Ixodes racinus, which occurs in Asia, and Ixodes persulcatus, which occurs in Europe. And the Lyme disease can be seen in all three regions. The Lyme disease can be stages like syphilis. In stage 1 to 30 days, you get erythema chronicum migrans. This is the site where the tick bites, and it causes rings of rash. The rings are called erythema chronicum migrans because they migrate. And you get conjunctivitis and episcleritis in stage 1. In stage 2, which is 2 to 3 months, you can get cranial nerve palsy, myositis, AV block, polyarticular arthritis, anterior non-granulomatous. Keep in mind that this can cause anterior non-granulomatous as well as choroiditis, optic neuritis, and parsplanitis. Parsplanitis is one of the features of Lyme disease. In stage 3, which is 3 months to 2 years, you may get meningitis, arthritis, and keratitis. This is just to show you how small the tick is. You may not be able to see it. It is very small, very tiny. This is the ear, and you can see inside the earlobe there is a small tick. So it's very hard to see the tick. And once they bite the skin, you can see the tick here under the microscope. And this is the spirochetes by fluorescein stain. And this is the skin lesion after the bite, showing the rings of the skin rash. Arthritis may occur in teenagers, and they might be mistaken for juvenile rheumatoid arthritis. And one has to keep in mind that this is caused by Lyme disease. These are snowballs in the anterior part of the vitreous, showing in a patient with Lyme's disease. The lab findings, you have IgG and IgM antibodies to Borrelia burgdorferi. They are usually positive. It can be done by ELISA or by immunofluorescence. PCR is available for the diagnosis of Borrelia, and false positive ELISA can occur in patients with syphilis and rickettsia. Lyme disease can be treated with either doxycycline or amoxicillin or azithromycin in stage 1 and 2. In stage 3, it requires penicillin or ceftriaxone. Now, leptospirosis, and I would like to complete and finish with this disease. Leptospirosis is caused by Leptospira, and Leptospira, it can be Leptospira interrogans or Leptospira biflexa. As I mentioned, these two organisms are the most common cause of uveitis in horses. The spirochetes is 6 to 20 micrometer by 0.1 micrometer. It has a hook, and spirochetes are motiles and can be detected by dark field microscopy. Especially if you want, you can take the aqueous of the horse and you can look for by dark field microscopy. Silver stain or fluorescein antibodies are available, or by PCR. There are two forms of leptospirosis: the anti-ecteric mild form and the ecteric. The ecteric is you get hepatitis associated with it, and it's usually called the Weil's disease and can cause uveitis. The reservoir of Leptospira are rodents, dogs, cats, birds, and horses. Transmission is from direct contact with urine, blood, or tissue of infected animals. Spirochetes can enter the skin if abraded or through the mucous membranes. This is a patient with anterior uveitis, posterior synechiae, caused by Leptospira, and this patient had anterior non-granulomatous uveitis. Anterior uveitis rarely cause hypopion. I told you most spirochetes do not show hypopion, but in cases of Leptospira, you can see hypopion. Vitritis may occur and retinal vasculitis. You can see this is another patient, and it causes mature cataract. This is hypopion and the anterior uveitis associated with it, and the patient has cataract. In fact, in India, you can see epidemic of mature cataracts just because of leptospirosis. There are epidemics of leptospirosis, and they are common cause of mature cataracts. I mentioned interrogans and biflexa, and this is a patient with Leptospira interrogans showing the evidence of retinal vasculitis with retinitis. The septic phase is with fever, headaches, and myalgias for 7 days, And in the mute phase, you had headaches and aseptic meningitis with skin rash, hepatosplenomegaly. Hepatosplenomegaly occurs in 10% of the ecteric form, and you may get renal failure associated with it. Leptospira should be treated with amoxicillin, or if you have somebody allergic to penicillin, you can give them doxycycline. So in conclusion, we can say that infectious uveitis are important cause of uveitis. Mistaking infections for autoimmunity can be catastrophic, because in patients of autoimmune diseases, you have to give immunosuppression, while infectious diseases, you will have to give specific antibiotics and not steroids and immunosuppression. So keep in mind that before you give Humira or before you give any of those immunosuppressive agents such as Cellcept for uveitis, you have to rule out infections in some of these cases. Thank you.